All right. Hello, everybody. Thank you so much for joining me today. My name is Kimberly Levitt. I'm the Health Programs and Supportive Services Manager at Bradbury-Sullivan LGBT Community Center. And I'm joined here today with Bryan Weinberg, a nurse practitioner at Lehigh Valley Health Network in general surgery, and Stephen Estrada, the Manager of Community Engagement at the Colorectal Cancer Alliance. And I also want to say a huge thank you to Olympus Corporation of the Americas for providing funding for this campaign. If you want to learn more about the campaign, visit bradburysullivancenter.org/colorectal cancer. So let's just get started and start this conversation. The first thing that I would love is to really hear from both of you about your personal experience and or any work-related experience of why you think this topic is really important for people to understand.
Bryan,
Steve,
I'll let you lead.
yes, Bryan,
Oh, okay.
why don't you go first?
All right. So, as a practitioner, on the healthcare end of it, of course, we know that, the risk of colorectal cancer. On the clinician end of it, my job is one of the things that we do is screening and setting people up, doing their medical exams to get them ready for colonoscopies.
Mm-hmm.
Of course, we know that, at age 50, there's a higher risk of colorectal cancer. And that if we can catch it, through a colonoscopy, that we, of course, reduce that risk significantly. So, so I see people get them set up, do their evaluation, and then they have their procedure done. On the LGBT side, in my doctoral work and even when I was in grad school and just being a part of the LGBT community, one thing I recognized is that there's a higher risk for anal rectal cancer within the LGBT community. So that was something that when I talked to Judy about this, that has prompted me to sort of in that connection with the clinical aspect of it.
Yeah, thank you. And Stephen?
So hello, everyone. I'm Stephen Estrada, and I am the Manager of Community Engagement at the Colorectal Cancer Alliance. I came to be with the Alliance through my own experience with colorectal cancer. When I was 28, I was diagnosed with inoperable stage 4 colorectal cancer. It was caused by a genetic condition called Lynch syndrome that was running through my mother's side of the family. It turns out my mother and my grandmother both had colorectal cancer. We knew about my grandmother. My mother actually was diagnosed shortly after me. She went and got a scan because of my diagnosis. I was given about a year to live. And so I went through chemo and I went through the surgeries where the cancer had spread was very sensitive. And it just immediately was told, no operation for you. So, time went on. I ended up joining a clinical trial, actually. Because of my genetic condition, I qualified for an immunotherapy drug. At the time, it was unnamed. I believe it's approved by the FDA for other indications at this point. But I spent about 5 years on that trial. 3.5 of those years were spent cancer-free. And actually, as of November 2019, I was graduated or booted off the trial. And then I think about 3 months ago, my oncologist called me and gave me another clear scan and said, this is it, the last time I want to see you. So I finally got to hear the other C word, which was I was cured. So, I was one of the lucky ones out there. But I share that because it really motivates me to do what I do with the Alliance. And that's a lot of patient education, patient outreach, patient support, especially for not just the person affected by colorectal cancer, but their caregiver as well. As far as the LGBT aspect, that would be me. I'm the G in the LGBT.
Me too.
So, yeah, right. You couldn't tell. But my husband, we've been together now for, 13 years. He was kind of a superstar caregiver, and so it really shocked me when I found out there were a lot of people in the LGBT community who didn't have that, and so that really put a fire under me to make sure that patients out there who are LGBT and beyond don't feel alone. So my motto is I try to be the person that I needed when I was diagnosed. And that certainly extends to my LGBT brothers and sisters out there.
Yeah.
Yeah, absolutely. And congratulations on, going through that whole experience and coming out. And now you're at the point where you're giving back. So thank you so much, up to both of you. This is obviously really necessary work. So there's a lot of questions now I'm ready to ask, but I want to just take a step back and touch on the one thing I do want to touch on is risk factors. So your risk of getting colorectal cancer increases as you get older. More than 99% of cases occur in people who are 50 years and older. So that's a high number. I think that's a really high number. So what I think most people understand is lifestyle factors can contribute to your increased risk, right? So the three of us understand that regular exercise, having a specific diet might help, or, reducing your alcohol consumption, not using tobacco, like all of those things will reduce your risk as you get older. How I guess, Stephen, in your position, and Bryan, with your patients, how do you educate patients about, or clients about, these risk factors?
It really goes to speaking to people where they're coming from. You can't just take a one pager and use very general language and pass it out to every community out there and expect people to take away what they need to take away. You have to have the right messenger, especially. I would like to backtrack just a little bit. While a majority of the cases of colorectal cancer are, in fact, in people over 50, what we now know is that from 2007 to 2016, the rates were on the rise for people under 50.
Yes.
That is another one of my questions, because I know 50, we always hear 50 years old, 50 years old. This is when you should start getting your screenings, but I know
Right.
there's a little bit of a blurred line there now. So I'm curious to hear from both of you of what you think of that.
Yeah. Oh, I'm sorry. Go ahead.
Sorry, Stephen. Go ahead. No, go ahead, Steve. I'm sorry.
I was going to throw a couple more numbers out there.
No, go ahead.
Right now, the rates for people under 55 is increasing 2% every year. The rates for people over 55 are dropping by, I believe it's 3.6% every year. So we're seeing this complete and dramatic switch of who's coming into the ER saying, I've got something wrong with me, I don't know what it is. And unfortunately, for people like me, doctors aren't quite ready for that lesson. This can actually go back to that education piece. Speaking to doctors where they're at and educating them about the younger people like myself who need colonoscopies, and more so than that, they need someone to listen to them and believe them.
Yeah, exactly. I was just going to add to that, Stephen. There was just actually, it was funny. I think it was last week. You get pings on your phone, and there was actually a Netscape thing that came through. Because I constantly get information about different guidelines, and one of the things that's been talked about was lowering the guidelines to actually 45 years of age, because you're right, they have found that actually the rates of colorectal cancer is, you're right, increased in the demographic that are less than 55, and it makes sense because we're not screening that versus people at 50. There are things that come up when you go to your primary care doctor, especially now with, Epic, there's reminders that come in and say, hey, your patient's 50 years old, send them for a colonoscopy. So that's really made a difference for people that are 50 years or older, but not people less than that. And I even, you brought up a very interesting thing talking about your the genetic component, which is something that also too, when we're talking about educating patients or when I'm evaluating a patient, I do sort of a genomic assessment. I ask about, your first degree family, is there any history of cancer, any colon cancer, any of that kind of stuff. It's very basic, but to screen about that, and I talk about, your risk, if you have a family member that has had any type of colon cancer, your risk are significantly increased too. So it's good that you brought that into the conversation. So it just made me think about that when you said that. So.
Yeah, I'm a big believer, and I tell this to every patient and every non-patient. Whenever I talk to someone about this disease, I really do believe that the most powerful weapon we have against this disease is our family history and knowing about it. Mm-hmm. My grandmother, all I knew growing up was that Meme had cancer. I didn't know it was a GI cancer. I didn't know anything beyond that. So it wasn't until I started presenting with all these symptoms that someone finally said, hey, Grandma had this. Maybe you should mention it. Not that it helped me at the time. I've mentioned it over and over and over, and I was really denied care.
Yeah.
But I think that educating people about their family history and just knowing that little bit could go so far.
Yeah.
What's hard about, when you talk about, missing that care, where that, you went to seek this care and you were denied care. There's a lot of times we as providers run into guideline restrictions, and it's sort of, it can be bothersome at times because, yeah, you could have a patient come in that is under 50. So of course, this would then, prompt what's called it would prompt a diagnostic colonoscopy versus a screening colonoscopy. But, I've talked about this where, if we could do the screening colonoscopy earlier, we would catch much more of this. If it had been, even younger than that, maybe they would have caught this earlier for you. So it's definitely a thing. And, we're always playing catch up, it seems like, with guidelines and in healthcare. So I think sometimes you're right. It can make us a little myopic in a sense, because we're always stuck to those guidelines because of, insurance reasons and stuff like that. But there's still this important factor of the patient in the care. And even, I think, as a provider, recognizing outside of that when somebody has symptoms, or even just, keeping in mind when you're assessing for something that could be in the background too. So very good point. Yeah.
Yeah, absolutely. I think one of the other big barriers with getting something like a colonoscopy is that people are scared. It's as simple as that. They're really nervous and scared. They don't know what to expect. They don't know how to prepare for it. What is some advice that you could give to someone who has never done it before, doesn't really know which way to turn, and really is just nervous and scared?
Okay. So on the, so with a patient, I think the first, you're right, the scared part is I think they're worried that they're going to be awake during this procedure. We do not, we do sedation for this procedure. So that sort of seems the biggest thing. Some other questions that people always have is there going to be any pain afterwards? And it's not. The camera that's inserted to look is very thin. And of course, so there's that. But in preparation, the big thing is, when I talk to patients, I go through the whole process of, what you do the day before, the clear liquid diet, the type of bowel prep, how to do that bowel prep. And then I go through the actual procedure. You're going to meet with a surgeon that's going to do this procedure. They're going to give you medication to have you take a nice nap, if you will, and then they'll do the colonoscopy, and then you'll wake up that day, go home, take it easy the rest of the day. But we also do a lot of engagement in our office where my scheduler will, when they talk to the patient, we give them written information and about everything. We always remind them that call the office if you have any questions, send a message through the portal if you have any questions. And then also we started about a week prior to your colonoscopy, one of our nurses calls you and goes over everything again with you. So to help you with that, so that you have that support system. And that way, if you have any questions, because I think people are worried about that too. Like, am I going to do something to mess it up or something like that? So we try to give, and we recognize that we needed to give that support to people from the time that they see me for their medical exam to the time that they actually have the procedure itself.
Kind of to add to that, and you hit on it very early on, you really don't know what you don't know. And so that's why the conversation about colonoscopies, I think, is just so vital. If you have one, you can tell anyone it really wasn't that bad. There is no pain. The risk is so low for anything to go wrong. But the chances of you, catching something early, I mean, and that right there is completely worth it. There are so many people who just wish they would have been able to get a colonoscopy early.
Exactly.
Right now the Alliance for March Awareness Month is doing a big push for screening. We're really trying to enroll as many people as we can and help them get them navigated towards a colonoscopy or even just a fit test. I'll just kind of throw something out there right now. We're doing a pledge to get screened for colorectal cancer, and that pledge can actually be found at pledge.getscreened.org. and you fill it out, and one of our patient navigators will actually follow up with you and help you through this process, dispel some of that, fear and those myths about what a colonoscopy is. As someone who has to get one every year, that little nap is worth it. So, if you're having a stressful day, you take a little bit of that Benadryl and you're good to go. So there's really nothing to fear about it. Embarrassment never killed anyone, so we got to open up that conversation because colorectal cancer does.
Exactly.
Absolutely. Yeah, thank you so much for providing all that information. One of the things I wanted to touch on as well, maybe this can be one of our last points, is really barriers for the LGBT community specifically. So I'm sure all of us are familiar, but not everyone is familiar. Not every healthcare provider is familiar that LGBT people fear discrimination and stigma when they walk into a doctor's office. They might not have health insurance. They might have had a really negative experience in the past. So I guess I would love to hear a little bit around that topic from both of you, and whether it's a personal experience or what can we say and what can we do as we're public health professionals. What can we do to really beat that barrier? And I know there's a lot of work being done, and we're just a little piece of the puzzle. But I love to hear a little bit more from both of you.
So speaking from my personal experience, coming out was traumatic for me. It was very, very difficult. It's still one of those, now I look back and it was a highlight of my life. But at the time it was terrifying. Having to go to a doctor and talk about anything you might be doing behind closed doors is difficult for anybody, especially when you are already facing discrimination that just kind of goes across the spectrum. My heart continuously bleeds for our trans brothers and sisters who are almost at every turn just hitting something else. I don't know that education is enough there. I think that goes beyond educating providers. Personally, and these are just my opinions, I think that we need to start actually going out into these communities and training LGBT members to be doctors. I mean, that would just be, in my head, like, someone like me diagnosing me would be so great, but I've never had that in my life. I've had doctors who are looking at, looking under my sheet, trying to figure out what's wrong with me, and I'm sitting there just terrified. So I think that education across the board, and trying to elevate those doctors and those nurses who are LGBT and trying to get them into positions where they're helping the community more, I think that would create such change.
So you're saying LGBT providers helping LGBT community?
Yeah, I think again, this kind of goes back to earlier. You need the right messenger to get that message across, and I don't think there's anything wrong with. I don't think there's anything wrong with that.
Yeah.
Can you guys still hear me? I'm sorry, I'm having a little bit of problem here on this end. You guys hear me okay?
Yeah.
Yeah.
Okay, I'm sorry. Actually, Stephen, I was going to add to that. So I'm at the very last bit of my doctorate of nursing practice, and my project is actually on LGBT education for healthcare professionals. It's a 5-module. I put it together. It's actually going to be implemented next week at the university that I'm at, Millersville University. Thank you. But one of the things that was a big deal was, you're right, you talk about education, understanding, you talk about our trans brothers and sisters, about understanding about using inclusive language, like, neutral, gender neutral, like saying they, them. I talk to my staff about that. If you don't know, use that. But even, and just, and how to address people, understanding about preferred name versus, and how to address that. You don't want somebody, and how dangerous that can be to somebody coming into your office that presents, as a female, and then calling them, by a male name, and there could be somebody in that office, that another patient that could have, very strong feelings about that. And I hate to say this, but follow them out. That scares me. That's a huge, I guess something to help, to educate our staff about that. So anyway, so yeah, so this the modules I'm doing, and the idea is, you're right, we as healthcare providers and nurses, doctors, we need to be educated about our history, just even about what it means to be LGBT. What does even that acronym mean? The different types of people in our community, the elderly, the youth, and then also our healthcare disparities, what contributes to those healthcare disparities, how we can interact with them, and even I even go into sort of a theoretically, if you will, talking about a basis of like heteronormative attitudes and beliefs, minority stress, and then also using like cultural humility to actually interact with patients, to make them so when they come in, we can break down those barriers. It can be very scary. And I myself have not had, well, I could think of a past experience where it wasn't that I left out information. I didn't tell, I was a young guy at the time. I didn't tell the doctors, about something. It was something simple, but I was scared about that. And then we're talking the early 90s. So that's when I came out, so I'm aging myself here. But even today, you talk about, your husband, I think about if my husband were to get sick and having to access the healthcare system and what could come at us, especially knowing it personally, like from research and everything else. And then, and seeing it over the years as a nurse, interacting, I've always been out, even in the early 90s. If I saw a patient and anywhere I was working, I'd go up and say, hey, listen, you know what? You got a family member here. I'm here for you, just to let you know, hey, I'm here. And so, but you're right, there's such a barrier to healthcare, and you're right, discrimination, bias, all those things are such huge contributors that are so significant to these healthcare disparities that our community suffer from. So.
Absolutely. And yeah, I mean, you nailed it on the head. I think one of the things I think about a lot, and we could talk about this for days, I feel like, but I think a lot of things that I do at the center is we do provide some of these trainings to healthcare providers, including people at LVHN, yes, where you work, Bryan, because we want people to be informed and understand cultural competency around this community in particular, because you will see a variety of patients come in. So we want to make sure that you're using their correct name, not their dead name, and make them feel comfortable. So when I think of creating an inclusive environment, I often feel like that's very difficult to adapt in a lot of situations. So it's a work in progress, and I think it's something that we can definitely continue to work on, and hopefully that just by taking that step, it will open a door for those who need to get screened, and continue to prevent. Do you have any other questions or anything that you want to hit on?
I think that I would just like to put out there for the LGBT community, the Alliance, the Colorectal Cancer Alliance, really is an incredibly diverse and inclusive organization. We're always looking for ways to expand that within every community. If you ever feel alone through a diagnosis, if you ever feel like you're not supported by your own family, the Alliance is here for you, and we are your family. We've got several LGBT members on our staff who are fully prepared to hold your hand throughout this whole process, whether it's pre-diagnosis, screening, whether it's halfway through treatment. We've got certified patient navigators who are trained in these types of subjects. So you don't ever have to do this alone. And if you want to find us, we're at ccalliance.org.
Thank you so much, Stephen. And same goes to those who are interested in learning more. If you're in the Lehigh Valley area, you can visit the Bradbury-Sullivan Center website to learn more about all of our events that are happening and supportive services, including our Rainbow Ribbons group, which is specifically for those that have been diagnosed with cancer or are caring for someone with cancer. We have we also have some information for affirming healthcare providers, including those at LVHN. So thank you so much to Bryan and Stephen for joining today. And I hope you learned a little bit more about colorectal cancer prevention.